As we know, Rett syndrome is an early childhood onset disorder with a prognosis of living well into adulthood. All of us have a very deep and loving relationship to our loved ones with Rett syndrome. And the underpinnings of this relationship are dependent on us having a true understanding of the nature of this diagnosis and acknowledging the real divide we must cross between the love and dreams for our children and the reality of the progressive nature of this disorder. Too often, our best efforts with physical therapy, movement, and positioning are not enough to completely prevent the onset of orthopedic issues in spine, neck, and hips. And we're grateful to have experts like Dr. Killian to help guide our decision making at these moments. Thank you for being with us today, Dr. Killian. If you're ready, I'd like to turn the screen over to you to begin your presentation. Okay, there we go.
Paige. Thank you, Paige, for the introduction, and we're so glad to be able to join all the families and wonderful girls at home, and hopefully this information is going to be of some benefit in guiding you down this long journey. So here's everybody in my office who makes my day go better than not. So our topics for discussion are going to include beginning with bone health and muscle tone abnormalities and how they play a significant role in affecting the treatment algorithm for scoliosis and for hip dysplasia. It's interesting to the orthopedist that 8 common mutations in the MECP2 gene account for almost 60% of typical Rett patients, and that insertions and deletions account for another 20%. But what is confounding to orthopedists is that we have seen that similar genetic defects may have a completely different clinical presentation, or what's called a phenotype. The geneticists tell us that some of that can be due to variability in the X chromosome inactivation and due to some complex central nervous system signaling. So for most orthopedists, our treatment options for girls with Rett syndrome are more customized rather than, quote, by the book. Beginning with bone health, certainly a careful fracture history, especially if there's been more than 2 or 3, is important in coming up with your treatment algorithm. Medications may play a small role in predisposing a increased fracture risk. Where is the child in terms of their pubertal development? What is their mobility level? What's their dietary intake? And in some cases, what is their mutation type? We know that fractures present a substantial burden for those with Rett and their caregivers. Oftentimes they occur unrecognized, and given the decreased pain sensitivity and communication issues observed, families oftentimes feel quite bad that there was a delay in diagnosis. For example, you can see there's a little non-displaced fracture of the distal femur that occurred when some range of motion was attempted after a period of weeks. And with some increased tone, the only thing that can happen is either the muscles relax or the bone bends, as you can see in this X-ray. Interestingly, the 2 natural history studies do not suggest that overall the bone density in Rett girls is statistically lower than other groups, according to our current data. But not all girls are the same, and we still feel that there's a lack of existing literature, and therefore more research to enhance bone mass and bone density is still very important, especially in non-ambulators. The current state of treatment involves increasing physical activity and certainly initiating vitamin D supplementation when they're low. Ideally, orthopedists would like to see the 25-hydroxy vitamin D level to be somewhere between 20 and 30. If we have had multiple fractures, then usually an endocrinologist will be involved in the care. And if osteoporosis is diagnosed, then there are medical management in the form of intravenous bisphosphonates that can be used to help improve bone density before orthopedic surgical procedures are planned. A little bit about muscle tone disorders. We're all familiar with these tones. We've either heard them from the physical therapist or from our treating neurologist. Spasticity, dystonia, and rigidity. Spasticity is characterized by an abnormally high muscle tone, which often unevenly affects antagonistic muscle groups. What that means is that when the therapist or the physician is moving the ankle, you'll suddenly feel an increase in tone, for example, in the calf muscle, and it can be detected as a characteristic catch. But in the absence of a contracture, oftentimes the tone can be overcome and the range of motion of the joint is within normal limits. Spasticity classically is seen in stroke patients, premature patients, and in my practice, spasticity as a primary diagnosis is not that common. This contrasts with dystonia, and dystonia is a significant problem in the Rett patient population. It's characterized as sustained or intermittent muscle contractions that cause twisting and repetitive movements, abnormal postures, or both. Classic is the head is tilted to the side where almost the ear is touching the shoulder, or rather than the legs being straight relative to the pelvis, now they're both pointing off in the same direction, and the appearance of the ankle and foot almost looking like a ballerina on point. Rigidity often develops in dystonia, and it implies that there's a co-contraction of the agonist and the antagonist muscle groups. Or another way of saying is that your quadricep muscle and your hamstring muscles are both staying turned on all the time, or the muscles that dorsiflex your ankle and plantarflex your foot, again, are turned on all the time, limiting range of motion and eventually leading to contractures. From the orthopedic point of view, we know that the onset of dystonia and Parkinson-like tremors portends poorly for ambulation. Drug management has been explored, but has not resulted in a permanent cure for this abnormal tone. And painful contractures or positions that interfere with care or orthotics can be addressed surgically, but relapse is greater than in spasticity. So we'll move on to scoliosis evaluation and management. 50 to 75% of girls will have a measurable curve as they approach the adolescent growth spurt. Almost 90% of girls will have a measurable curve at the end of their growth spurt. Dr. Percy's work showed that the clinical severity score was greater and the motor behavioral assessment was significantly worse in girls with scoliosis compared to girls without scoliosis. In addition to the MBA, further research showed that there's an abnormal pubertal growth spurt in Rett girls, and genetic mutations are now being further evaluated to help identify this risk of progression. So, can you predict the 10% that will not develop scoliosis? Well, based on the material that we have presently, a low total MBA score, continued ambulation, normal bowel function, and either the R294X or R306C genotype results in a very unlikelihood of a significant scoliosis. But parents tend to worry about those factors that may lead to a girl developing either a non-surgical 35-degree curve versus a 60+ degree, which is considered to be a surgical curve. Well, puberty plays an important role in affecting progression of scoliosis. In the general female population, onset of cycles occurs approximately 14 to 16 months after peak growth velocity has occurred. This graph is designed to show you a slow, steady increase in height in a young lady, and then from this point to this point, the slope of the curve increases, indicating their peak growth velocity. And then sometime around here, between 13 and 14, there's the onset of cycles, and that contributes to the growth velocity decreasing and in adulthood being reached. In the bottom curve is another way of looking at the same time. Your child is growing perhaps 4 to 6 centimeters per year, and there's a slow, steady rate of increase, and then there's this big bump, and the bump occurs usually between 10 and 12 years of age, and again about a year to year and a half after that, there's the onset of cycles, and the graft rapidly goes down so that there's no more increasing height or truncal height, and skeletal maturation has occurred. So if we're able in hindsight to plot out when did the peak growth velocity occur and when did cycles start, well, those are two historical data points that now allow us to tell the family that the risk of scoliosis progression has passed. But we want to be able to predict, and so these are historical data and really don't help us in seeing a patient for the first time and assessing their initial X-ray. Continuing on with puberty, we've learned through Dr. Percy's work that a quarter of girls reached onset of adrenarche by about 9 years of age, half by 11, and then there were some late bloomers who didn't reach the onset until 12 and a half years of age. But only half of these girls reached onset of cycles by 14 years of age. And with a range of 8 to 23, it tells you that the message that tells the spine to stop continuing to bend and twist may be not delivered in a timely manner to completely arrest the progression of scoliosis. We know that being underweight was associated with a later age of adrenarche, and higher BMIs, or being overweight, was associated with an earlier onset of puberty. Some of the genetic testing from Greenwood has shown that girls with C-terminal deletions and early truncating mutations reach pubertal stages earlier, which means that rather than waiting until 10 years of age to start scoliosis screening, scoliosis concerns are much earlier. And those with PR168 mutations reach puberty later. So you may have a 15-year-old, but you may still need to be concerned that there's a continued risk of scoliosis progression based on those genetic mutations. So while the pubertal course in Rett syndrome may be abnormal, sometimes with earlier adrenarche and delayed menarche, the orthopedist is tasked with trying to figure out how do we apply the peak growth velocity, and basically we know that in Rett syndrome, it does not follow the rules. Therefore, the risk of scoliosis curve progression is altered. So in the evaluation of spinal deformity, scoliosis progression varies with the following items: the amount of growth remaining, the initial angulation or severity of the spinal deformity on the first X-ray, whether or not there's some genetic risks that have been identified, such as ARG255X and large deletions having a higher incidence overall of curvatures compared to some other deletions, such as ARG306 cysteine. And lastly, abnormal tone and contractures, particularly dystonia involving the hips and the trunk, are of concern. Curves can be grouped based on the rate of progression. Mild curves are said to progress 3 to 5 degrees a year, moderate 6 to 10, and severe are almost worsening in a matter of months. The first evaluation of scoliosis implies that the X-rays all have to be taken the same way. And for girls who cannot sit independently, all of their X-rays should be taken laying down. and girls who walk unassisted should have their x-rays taken standing up so that you can compare each set of films to the historical films. We consider scoliosis to be significant when the curve reaches 25 degrees. 25 degrees usually signals that there is a risk of continued progression of the curve in non-syndromic individuals of almost 80%, and we apply that same data to girls with Rett syndrome. Curves that are located between the scapula can damage the heart and lungs if they reach 100 degrees. So here's a 42-degree curve that ultimately gets up to 102 degrees, and at that point, the injury to the heart and the lungs is measurable. Progressive lumbar curves, in contrast, lead to poor sitting balance. The therapist and the parents have a great deal of difficulty trying to keep the pressure evenly distributed over the pelvis and the back of the thighs. If you add to that windswept hips that don't want to be controlled by an abduction pillow, and the possibility of pressure sores over the greater trochanter and pain contribute to treatment issues. So curves can vary just as they do in non-syndromic conditions. They can be between the wing blades and in the lumbar spine. They can be a single curve in the thoracolumbar area with pelvic obliquity. They can go from the base of the neck all the way down to the pelvis. And if in consultation with the family, the question will come up, should the curve be treated? So brace wear has been used as a means of slowing down the rate of progression. Brace wear in ambulators is well tolerated, but we do not have a prospective study that supports the concept that bracing can halt scoliosis progression associated with Rett syndrome. And therefore, most physicians will lump ambulatory Rett girls into the group of other similar syndromes in that they experience variable progression. If brace wear is initiated, then standing x-rays in the brace should record a measurement that is between 30 and 50% less than the original x-ray. We certainly want the brace to be able to squeeze them hard enough to make that investment in time appropriate. If there's a decision to use what's called a bending brace or a nighttime brace for a single lower lumbar curve, then all those x-rays should be taken laying down, and the brace should measure the curve to be 50 to 75% less than the original x-ray, indicating a well-made brace. As you saw, there's a difference in these braces. The recumbent or nighttime brace opens in the front, and the full-time brace wear or standard TLSO opens in the back. But in general, brace wear is poorly tolerated in girls who do not ambulate. This can be due to the brace being pushed up due to diapers. Number two, the front of the brace may settle on top of the thighs. G-tube feeding at night oftentimes requires loosening of the brace. Abdominal discomfort and distension can also complicate brace wear. And in general, curve worsening in this group is associated with other neurologic groups such as cerebral palsy, and curve worsening is almost inevitable once you get to a certain degree of curvature, that is 35 to 50 degrees. Brace wear, however, may have a role in the management of girls with severe hypotonia in order to better position them in their chairs and facilitate the use of communication tools during that particular part of their day. Well, bracing, if initiated, is continued until growth is complete. Two different ways of assessing growth is to look at the pelvis x-ray and As you have finished your peak growth velocity and cycles are about to start, a white chalk line or a rainbow begins to form on the top of the pelvis bone. It begins in the front and gradually works its way all the way back to the posterior aspect of the iliac crest, and then eventually it glues itself or fuses to the iliac apophysis. So you're considered to be almost completely finished growing by the time you get to Risser 4, and Risser 5 indicates all your growth plates are now closed. Occasionally in girls who have markedly delayed onset of cycles, but yet appear to be skeletally mature, you'll get x-rays of the hand. And again, you're assessing the presence of the growth plates in the metacarpals, phalanges, and eventually these growth plates are supposed to disappear and the two ends of the bone fuse, again indicating that growth is complete. If you are successful for brace wear and you end up with a curve that is less than 15 degrees, then monitoring into adulthood is not required. We believe that those girls will do well and not be at any increased risk of back pain as adults. If your curves are in the 40-degree range and non-operative management has been the treatment course selected by the family and by the physician, then continued monitoring into adulthood would only be required for new onset of pain or increasing truncal imbalance. That is, you're leaning to the side or shifting to the side. However, curves that are more than 60 degrees and non-operative management has been selected for that patient, then they probably do need to be monitored by a pulmonologist into adulthood to look for evidence of diminishing pulmonary function. So some of this data indicates that obviously progression in girls with Rett syndrome is multifactorial. Some of it is genetic related, some of it is related to their BMI, some of it is related to other complex factors, and predicting which 30% of all girls will develop a surgical curve is still not an exact science. So if the family and the orthopedic surgeon get to the point where we now have a large curve, the decision becomes who needs surgery and what should be the timing of that surgery. In general, the surgical indications are, number one, loss of sitting balance. If looking at your child from the front, they're leaning over the side of their wheelchair and no amount of padding or strapping will keep them in a comfortable position, then you may be at that fork in the road where surgery needs to be discussed. Rigid curves in the 35 to 50 degree range that are present in girls who are still growing are part of the discussion for whether or not surgery should be considered. Sagittal balance means that the patient can no longer keep their head centered over their pelvis. So either a collapsing kyphosis or a rigid kyphosis with loss of lumbar lordosis makes it difficult to keep her satisfactorily positioned in her chair. And in order to allow her eyes to look forward, the wheelchair has to be progressively tilted backwards in order to allow her to use her communications board. So we're going to divide surgical management into two groups. Rapidly worsening curves in children under 8 years of age is first, and they certainly pose certain challenges. Lung development is not complete, and the growing spine has not yet hit its growth spurt. So for that, several different options were developed to try and handle large curves in children who are markedly immature. The growing rod was developed as a way to delay definitive surgery and allow truncal height, that is the measurement from your shoulders to your hips, to get to its maximal. Curves that are in the 40 to 60 degree range are considered for growing rods, and it is important that there be moderate flexibility on stretch or supine bending films. Also, it is very important that there be an adequate amount of what we call fluff, but subcutaneous fat, in order to cover the bulky implants. The contraindications to growing rod surgery, number one, is that the pulmonologist fails to clear the patient. Either there is increasing difficulty with reflux, diminishing weight, would tend to make you not a candidate for a growing rod. If seizures are now a problem and we are poorly controlled on medications, that would delay a recommendation for surgery. And lastly, a relative contraindication would be a severe kyphosis. There is no way to put a growing rod that would go from the pelvis around this large deformity and attach to the upper part of the spine and not have that instrumentation fail due to the kyphosis and the bending of the rod. There are several different ways of trying to address severe spinal deformity that is of early onset. A modification of a rod that was developed in San Antonio has been applied in girls with Rett syndrome. This rod attaches to the lumbar spine and then has a special cradle that can attach to a rib. And this device can be made longer to manage the curve and keep it from returning to its pre-surgical state while still allowing the trunk to get longer. That technique was then modified with the manufacturers assisting orthopedists to develop screws that were more applicable to younger individuals. In this case of a growing rod, screws are attached, or sometimes a hook, are screwed into the bone at the top and the bottom of the spinal deformity. Bone graft is added in this area in order to make it like a block so that it is more stable and these tiny screws do not pull out. And then a rod is inserted that is longer than what's needed, and there's an initial correction of the deformity at the first surgery. This extra length then allows you to come back, loosen these screws right here, and push on this rod so that you can continue to elongate or lengthen the spine while the child is growing. So both of those techniques involve a manual elongation of the rod. And this can occur every 4 to 6 months depending on growth spurts and general medical stability of the patient. Each time the patient has to be put to sleep under a general anesthetic, and every time we make an incision through a previous scar, the risk of infection sometimes seems to go up. There has been some research because corrosion has been noted around these rods because they do move and there's metal debris that is created, and titanium and aluminum ions have been measured in the urine of patients. To date, this is still of unknown significance. No one has ever shown a malignancy developing around the rods or in the soft tissues around a growing rod. In an attempt to diminish the number of times patients undergo a general anesthetic, a new technique was devised in which this mechanism was made use of a magnet to power the screw mechanism to make the rod longer. So in the same growing rod technique, a different type of rod is inserted, which has magnets in it, and these can be manipulated to make the rod appear to become longer. So these magnetically controlled rods have an advantage in that you have in-office elongation occurring. It's still considered to be painless, but because there are now some complex moving parts, rod binding and failure is still an issue, and our experience is that there seems to be more metal debris that is noted when you have to remove or replace one of these rods. In addition, the metal is different, and again, vanadium ions have been noted in the urine, but to date, this significance remains unknown. Another technique that has been developed involves vertebral body tethering scoliosis. This has been applied for normal idiopathic scoliotic deformities that are extremely flexible and has not yet been approved for neuromuscular diagnosis unless it's used in an off-label manner. But in this surgery, the screws are placed in the front of the vertebral body, which means that you have to enter the chest and enter the abdomen in order to place the screw. And then the screws are all connected with a type of clothesline, not a rod. And by tensioning this clothesline, it provides some degree of decrease in the magnitude of the deformity. But the whole premise of this system is to prevent progression and perhaps obtain some improvement in the deformity. And the predicate is that there needs to be normal growth potential. If we look at all of our growing rod techniques, ours and everyone else, if you include major and minor complication rates, you can get up as high as 99%. There can be problems with wound breakage, hardware breakage, wound infections that all lead to revisions of the hardware or having to develop a new treatment algorithm for that girl. So moving on to definitive spinal fusion treatment, that discussion is usually occurring in patients who are over 10 years of age who have large curves in the 50 to 60 degree range. Now, the flexibility of the curve does enter into our decision making. Somebody who has a 60 degree curve that when you simply stretch them bends down to 10 degrees is very different than somebody who has a 55 degree curve that only bends down to 49 degrees. And certainly stiff lumbar curves with worsening pelvic obliquity are not curves that we tend to want to watch, because the amount of correction that you can get 9 months or 12 months later is always much less, or other factors make the surgery longer or increase the amount of blood loss. But in both of these examples, there's never a sense of urgency. This is a process that should be planned for and undertaken after adequate medical clearance. So in definitive spinal deformity correction, again, multiple anchors are placed into the spine, either screws or hooks or clamps, and then the hinges, which are the facet joints between each of the vertebral bodies, are removed. And by removing that, you now unlock the spine, which allows for a carefully contoured rod to restore a gentle amount of thoracic kyphosis and restore the proper amount of lumbar lordosis so that sitting is optimized. Fixation may extend to the sacrum or into the pelvis in non-ambulators and usually stops above L4 in ambulators. Bone graft is added, and bone graft is the key to successful healing in that everything needs to be glued together. The transverse processes have to be glued together, the lamina have to be glued, the spinous processes all need to be glued together so that all of this hardware is covered with a thick fusion mass which will continue to support the child, and this fusion mass will increase in density over the life of the patient. Here are some examples. We see a marked pelvic obliquity, loss of good sitting balance, windswept legs, and loss of lumbar lordosis, and a gentle upper thoracic kyphosis. And your goal is to restore your pelvis so that it is flat on or perpendicular to the overall spine, and that some degree of lumbar lordosis is restored so that sitting position is more physiologic and your head is now centered back over your sacrum. Another example of severe pelvic obliquity with a large thoracolumbar curve in which you reestablish a level pelvis and the spine centered over that level pelvis. And then another girl who has a large thoracolumbar curvature as well as kyphosis, marked pelvic obliquity, and an ambulator, which makes her legs appear to be markedly uneven, with decrease in the thoracolumbar kyphosis to a more physiologic alignment and leveling of the pelvis. In general, spinal deformity treatment is about a 3 to 5 hour long operation. Blood loss, it can be from 2 to 6 units of blood. There are many factors such as cell saver or other drugs that we use to diminish blood loss during the surgical procedure. Most of our girls only spend one night in the intensive care unit. Feeds can resume on post-op day 2 or 3 if bowel sounds are active. They're up in their wheelchair the next morning, and post-operative bracing is rare, and most girls go home after day 4 or 5. Narcotics are used usually at nighttime for 1 to 2 weeks, but energy levels seem to be normal by 1 month of post-op, and most girls are back in school. And the only thing we ask the physical therapist is to avoid aggressive hamstring or hip flexor stretching for the first 6 months if there has been fixation into the pelvis. The spinal fusion should be solid at 6 months. And final x-rays at 2 years post-op should confirm that there's been no loss of fixation and that you appear to have a solid arthrodesis. In general, the benefits of a definitive spinal fusion are to stabilize pulmonary function. You certainly improve your seating options of having a less complex sort of seating prescription being required if your pelvic obliquity has been corrected and now your head is centered over your pelvis. And in my practice, I think it's still anecdotal that parents will indicate that GI issues seem to be improved compared to preoperatively. If we look at definitive fusion techniques compared to growing rods, the risk of wound breakdown is much lower. Hardware breakage should be very low, and most of the readmissions are due for urinary, pulmonary, or GI issues that are usually unrelated to the actual surgery. Moving on to hip dysplasia. Hip development is dependent on proper alignment of the hip. You have to have good muscle tone. You have to have a normal femoral head, which means the femoral head has to be nice and round and not misshapen. You also have to have a normal hip socket, and the two of these need to be in close alignment with each other in order to promote good growth and development. And lastly, you have to have a normal labrum, the O-ring that wraps itself around the femoral head and keeps the femoral head pushed deep into the pelvis, contributes to the growth and development of the hip. Hip dysplasia occurs if this labrum, the O-ring, is small. So there can be girls with Rett syndrome in whom they inherited a small labrum from great-great-granny who developed hip dysplasia when she was an adult, but may not be diagnosed initially at birth. And girls may develop hip dysplasia because of abnormal muscle tone. So hip subluxation is said to occur on the x-ray when the femoral head is not seated deep in the socket. So rather than the entire femoral head being deep against the acetabulum, there is now an increasing space or migration of the femoral head away from the socket. Hip dislocation occurs when the femoral head no longer touches the socket. So the acetabulum is down here, it is markedly abnormal, and the femoral head is now rubbing up against the outer wall of the pelvis. If hip dysplasia is recognized early, either because of an incidental pelvis x-ray that was taken because of a GI issue, and it's noted that the acetabulum appears to be immature or the femoral head is not deep in the socket, then several types of non-operative management, including nighttime brace wear, can be instituted. And oftentimes, under 4 years of age, we will get some improvement and be able to avoid surgery. However, because of the tone issues that we mentioned earlier, the hip may prematurely move out of the hip socket and become severely subluxed or dislocated. In neuromuscular conditions such as Rett, premature painful arthritis can develop in untreated hips. And the current philosophy is that the hip is much better off repositioned in the acetabulum rather than being left out. The reconstruction for hip dislocations involves, number one, lengthening the tendons that are limiting or contributing to a restricted range of motion. If the socket is deficient or lacking, then an osteotomy will be made somewhere in the pelvic bone and a wedge of bone inserted in order to improve the amount of contact between the acetabulum and the femoral head. And if there is an abnormal twist in the upper end of the femur that may have also contributed to the hip moving out of the socket, then a second osteotomy will be performed in the upper part of the thigh bone, and the femoral head will be rotated and positioned so that, again, it has a good match against the acetabulum, or is said to be congruent. And a plate and screws are used to help hold that in place. Some of the limitations in performing this surgery is certainly bone stock. Preoperatively, we think it's very important that their vitamin D levels be maximized in order to allow for obtaining the maximal amount of correction of the deformity. Because the plates and hardware that we used are very small, usually you have to place them in a spica for 4 to 5 weeks. Some of the older kids may not be treated, with only a knee immobilizer and a wedge between their knees. For girls that are ambulatory, gait retraining may take them 6 to 12 months before they are walking well again, or as well as they were preoperatively. Excuse me. In general, postoperative infections are rare. Occasionally, this femoral plate is big enough and the girls are small enough that it will irritate the iliotibial band and will have to be removed 1 or 2 years later. Even though we may not remove any bone from the femur, but in the process of repositioning it or tilting it downward, sometimes we cause a 1/2 inch to 1 inch shortening of the affected femur. And in ambulatory girls, a lift may be required in order to help balance or level the pelvis. The most important thing to discuss with the family before surgery is that there is going to be a limitation of hip abduction after this surgery, or getting your child to sit in the W position. There will be a limitation in how far that hip can externally rotate and abduct compared to the other side. And this is not likely to get better with physical therapy. But what do we do when we suddenly see on an x-ray a hip that is obviously terribly misshapen and is nearly completely out of contact with an acetabulum that looks like it has no form to it whatsoever? The hyaline cartilage, which is the Teflon coating on the top of the ball, so the entire top of this should have a clear white smooth appearance to it, almost like a cue ball. And when you have bone-on-bone contact, that also leads to loss of the hyaline cartilage. And as I said, if the acetabulum has never developed normally, there are some challenges in terms of trying to recreate a socket that is essentially flat like a saucer. In those cases where arthritis is already present, the only option that will give good pain relief involves complete removal of the femoral head so that a space is created between the pelvis and the rest of the thigh bone. The leg is markedly floppy for a period of months, but eventually there's pain relief, and eventually there's improved ability to position the girl in their wheelchair and have them sit. The most important thing to understand, though, it is nearly impossible to ambulate after what's called a girdle stone femoral head resection procedure. So we've talked about the importance of bone health and how maintaining a good bone density in these girls is important, both in how it aids in maintaining good muscle tone, as well as making it surgical procedures to be less complicated with hardware failure or delayed healing. We've talked about how dystonia and rigidity in particularly add to the complex decision making that is required when performing orthopedic surgery. Dystonia in particular is frustrating not only to the orthopedist, but as well as to the family and the physical therapist, and hopefully medical management is on the horizon. With regards to spinal deformities, I hope this information allows the family to feel more at ease with that fork in the road that may present to them when that x-ray shows the curvature has gone from 10 degrees to 30 degrees, and that you'll have a better understanding of the options that are available then, and why some decision-making options will be available, and why in some certain circumstances a certain surgical option might be less indicated or contraindicated. And then lastly, with regards to hip dysplasia, sometimes hip dysplasia is a result of genetics, not related to Rett, in that some girls are just born with a deformity of the upper femur or of the acetabulum that then predisposes them to developing a hip subluxation or hip dislocation. And again, the problems of tone involving dystonia or rigidity make the surgical management of that the preferred option when bracing has no chance of putting the hip back into the socket or leading to what's called a congruous hip. So throughout my career, I'd like to give a special thanks to Alan Percy for all the education he's provided to me and the care and treatment of his patients, as well as the results of the natural history study. And for the people in my office, Dr. Mayberry and my staff, who's allowed me to visit Oakland, Miami, Tampa, Chicago, and New Jersey, and see for myself the natural history and the orthopedic manifestations, both in the skeletally immature and grown adults up to 40, 50 years of age. And that has certainly been a wonderful educational process for me as an orthopedist and as an educator. Paige, thank you. And to all the attendees, I look forward to any other questions I can answer for you.
Thank you very much, Dr. Killian. There's a lot of information, really dense. I'm sure people will be going back to the recording and revisiting. But if we can stay in your slides right now, we have a number of questions that were submitted before the webcast and that have come into the queue during your slides. And I hope this will allow for a little bit more of a conversational tone with the issues that our families are facing today. And by staying in your slides, you can flip back to anything earlier in your presentation to give a visual, if that's okay.
That'll be great.
Fantastic. Okay, so the first question, and you answered a lot of these, but I think because they are issues in front of people today, it's worth hitting them again. The first one is questions about when an orthopedic referral should be made. Should it be made at the, right after a new diagnosis is received, or wait until scoliosis or hip issues are suspected? What's your recommendation?
Well, I think if a girl has never ambulated, and if there is any suggested limitation of range of motion or the appearance of a leg length inequality, then I think they should be evaluated. So in general, most of those patients are going to be between 14 to 18 months and 3 years of age. So we get concerned about the hips in someone who either ambulated and lost the ambulation or have always had profound hypotonia, but especially if the pediatrician or parents feel that there's a clicking, comma, popping, comma, or limitation of range of motion exam, then they should all be seen.
Okay, thank you. Next question is, how aggressive do you think families should be with exercise, positioning, and bracing to prevent scoliosis and hip issues from developing?
Well, we think physical therapy is important in terms of taking every single joint through what would be a normal range of motion. Obviously, all of us are committed to one day developing a cure or obtaining a cure. And depending on when that comes and to which select group of girls it is best applied, having a flexible hip, knee, ankle, and upper extremity is obviously important. There's no single paper that will tell you that you can produce bone density through passive range of motion. And there's no single paper that will tell you that you can absolutely prevent a contracture from developing just through physical therapy. But because of the sort of altered sensitivity in the lower extremity, in particular in girls, I think the more that you manipulate them and put them in a stander, I think all of that's beneficial long term. And for what little biofeedback that probably occurs through weight bearing, pursuing weight bearing is still to be encouraged, be it in a stander or by maximal standby assistance by the family or by the staff or the physical therapist.
Great. I couldn't agree more. I think there are a lot of benefits to movement and aggressive therapies beyond some of the prevention aspects. So thank you for responding to that. Next question is around bracing. Do you feel that, do you have an opinion on the need for bracing, how early, and the different types of bracing options that families are being offered these days, such as soft supports, like a SPIO vest or SPIO system, versus advancing to a hard plastic TLSO? Can you talk about that a little bit?
So we're just going to address that, I guess, in non-ambulators, girls who spend more time in their wheelchair than are that. I think you have a long conversation with the family. Girls who have an increased BMI who are more difficult to get a brace to fit them. So while you may have a conversation about that to the family, you may show them some examples of your patients who have the same body habitus and show that despite the orthotist doing his best, the pre-brace x-ray that measures 35 degrees with the brace on measures only 32 degrees. So the committing to the use of a brace is really not going to be something that you're going to encourage the family to pursue. If your sole goal of the bracing is to address problems with positioning because of abnormal tone, then certainly all of those can be, soft brace in particular, can be pursued as they may allow the child to be in a more comfortable position for use with their communication tools. But there's certainly an ideal body habitus for somebody who's going to do better than not and perhaps avoid having to go through growing rods only then to have to go through a definitive surgical procedure. And that's going to be someone who has sort of an ideal BMI. They're not overweight and they're not so skinny that they have prominent bony areas. And number two, after you take the x-ray that shows the deformity, you back that up by an x-ray that shows that they're extremely flexible. Then certainly steering that family towards a trial of brace wear, as opposed to telling them they need to begin a growing rod, I think that's reasonable. You're not burning any bridges. And if the child grows 1 or 2 years and their weight improves, and if there are ongoing problems with other health issues they're allowed to resolve, then the child is a little bit bigger, they're a little bit healthier, and if the curve truly has worsened, then they may be in a much better position to tolerate a surgical procedure with fewer complications.
Okay, thank you. We've had a lot of questions come into the queue about positioning during x-rays and what conclusions you draw for that, from ambulatory children to non-ambulatory children, sitting versus lying, braced versus not braced. Could you spend a little bit of time helping us navigate the interpretation of those results and what you recommend in your practice?
So if our patient is ambulatory, we're going to try and get all of those x-rays taken standing up. It just makes everything easier to compare to and gives some reliability of your measurements. If we're not able to ambulate, then our preference is to take them laying down. Now, occasionally you'll take a seated x-ray. Because somebody will have gotten an x-ray and they're told their child's curve measures 20 degrees and that they shouldn't be worried about it, but the parents are there for the express purpose that they think the child is not sitting up well, or they look more crooked than the x-ray would suggest. So there's a time when we will take a seated x-ray in a child who is a non-ambulator. And there's certainly a great deal of variability in those films. In the morning, the child may be bright-eyed and just have more truncal tone, and they may look great. And then at the end of school, when the family comes for a 4:30 clinic appointment, that same child may, in a seated x-ray, look like they have a 45 or 50 degree curve. So sometimes the seated x-ray is used as a way of reaffirming what the parents or the physical therapist are seeing, and that they have increasing difficulty positioning the child. But for surgical planning, we're looking for a stiff curve to make the recommendation that the family now needs to pursue a different treatment algorithm. And therefore, if I take all of my x-rays laying down, then that's an easier way to show the family the progression of the films and that they are now at a point where they need to consider a second treatment option.
Okay, thank you. Next question is around alternative interventions. And we've had a couple of people ask about visiting a chiropractor, and if you're, in your opinion, if that is something of benefit for children with scoliosis.
Well, most of the gentlemen in the state of Alabama with whom we have a good working relationship know that at a certain point in time, the deformity is rigid. And while the generalized physiotherapy aspects of a massage can be said to have certain benefits, and we're not, we wouldn't take issue with the chiropractor saying that there's some generalized physical effects that are a result of manipulation or massage type of activities. But to date, at least the Scoliosis Research Society Educational Committee has yet to find a study that shows that manipulation has ever been able to make a 40-degree curve go back to normal, which would be less than 15 degrees. So I think in general, we would not say there's anything negative about doing it. I think if it addresses some other issue, if some families believe that somehow it affects or improves GI function or makes their legs more flexible, we wouldn't take issue with that. We'd say continue to do it. If that's the best way for you to restore range of motion or flexibility in the lower trunks, then by all means do that. But in terms of a definitive study that proves in neuromuscular scoliosis, you can make it decrease or halt progression, there's just not a paper that I could show the families that would say, absolutely, you should pursue it.
Okay, thank you. Thank you, I appreciate that recommendation. And I think this leads into our next question, which is not specific to scoliosis or hip issues, is a problem in general with Rett syndrome, is helping identify the location of pain in our kids. Many parents experience feeling our children are in pain, having trouble identifying specifically where that pain is. And I think with scoliosis, there's a time where you're pre-surgical, but you're worried that her position is painful for her. Do you have any recommendations or ideas or suggestions that you have found fruitful for the physical therapist or family to help identify if pain is present, if it's present because of spine or hip or other kyphosis? Can you talk about that a little bit?
Very good question. And so when we have someone in whom we'll just say that the curve is less than 60 degrees, the wheelchair appears to be more than adequate. There are no abnormal calluses or skin irritation over the bony parts of the spine or lumbar area. Internal and external hip rotation seems to be easy without significant spasm. And the x-rays in both cases do not show any evidence of severe degenerative changes in the hinges in the lower back or in the femoral head. Then yes, we're at a loss to try and explain then what is bothering the girl. So at that point, we sort of have to do the $1 million workup. We begin to look at obviously laboratory studies to show, is there some inflammatory process going on? Sacroiliac infections are notorious in neuromuscular children for having a profound delay in diagnosis, and they are difficult to identify. So if the laboratory studies are normal, then that's reassuring, but we'll probably still follow that up with a bone scan. A bone scan is sort of a generalized test like a CBC in which you inject a medicine, and that is supposed to go any place where the bone is inflamed or irritated. If that aids in pointing to a specific area, then that allows us to follow that up with either CAT scan or MRI. If the bone scan is completely normal and all the laboratory studies are normal, then we will have to ask the gastroenterologist to reassess whether or not we're having visceral pain that is mimicking orthopedic or bone pain, and ask them to, complete a workup to aid. And if both of us are negative at that point, then we're sort of scratching our heads as to what do we do. If there is a significant limitation of range of motion in the hip, for example, and the bone scan doesn't show anything, then we will oftentimes get an ultrasound of the hips to see is there fluid. If again, because low-grade infections can occur in anyone, even girls with Rett. But most of the bad things are going to have a new onset of stiffness or loss of range of motion compared to what has been the general physical examination of the girl. So pain is a unique problem. We don't ignore it. and typically we have to do multiple tests to rule out all the worrisome things. And in the vast majority of cases, it resolves. It may take weeks or months, and oftentimes the families are frustrated. But if the gastroenterologist can't find an obvious source for that, and even including a ultrasound of the abdomen to look at the lower part, ovarian follicles bursting, fluid in the cul-de-sac, etc. You then come back to the fact that at least orthopedically, we can reassure you that your child does not have arthritis in the lumbar spine. They don't have an infection in their sacroiliac joint. There's no obvious evidence of an infection in the pelvis or in the hip joint. And they're either having GI-related issues or maybe they're having painful spasticity. Does that help?
Thank you. Thank you. That's very comprehensive and is a very big issue with families. So thank you for walking us through that. And I'm sure people will be rewinding in the recording to go through that list and share it with their practitioners. We have a lot of questions as well from parents who are at the stage of having conversations about intervention. And I'm wondering if you can revisit the growing number of options that are not FDA approved yet, where there may not be a lot of published information, and parents are being asked to make decisions about growing rods, magnets versus non-magnets, tethering, ASC, APIFIX, if I'm pronouncing that correctly. There's just a lot of options being presented to families. How would you help families make the right decision and know that they're getting the best recommendations when there's not a lot of literature in this area yet?
Well, I think you look at what has been the progression in that physician's practice with the use of technology. Certainly, if a new technology has been applied in simple, uncomplicated situations, and the success rate in that physician's hands is very good, and you have a good relationship with that individual, then being open to new technology innovations is certainly something that you can pursue. That is usually easy to introduce to families in whom the individual or the patient is completely normal. When you have comorbidities, as we do in Rett, in terms of sometimes their low body weight, seizure disorders, high-dose seizure medications, severe abdominal bloating, and chronic constipation, then telling the family that there's a chance that we may have to revise the surgery or we may have to bail out and do something else is a significant risk to the patient themselves. So finding the parent who says, you know, we are committed and our daughter is healthy, that we know that if this is going to take 2 or 3 surgical procedures to get the end result, which may only be to have her sitting 3/4 of an inch taller than she would be if you went with option B, then that's a family who can pursue that with that surgeon. But most families, when you present that to them, think long and hard about how many times do they want their daughter to go through multiple surgical procedures, as well as the toll it is on the family in terms of how long they may or may not be out of school or return to their normal activities. So for us, it boils down to you look at the x-ray, you then look at the patient, and you then evaluate the family. And depending on what seems to be the best treatment algorithm is what we typically present first. And if the family says, well, we'd like to go with the other option and we'd like her to be an inch taller, and even if it means a 2-year process, we're willing to go through that as opposed to a 4-month process to do a definitive surgical procedure, then I think you should present that to the family. And if it involves new technology with which you're very comfortable with, and you have already shown to work well in uncomplicated individuals, not just based on the x-ray, but looking at the total individual, then I think those other new technologies are certainly things that we do as well. Does that help?
I think so, and I hope so. And if not, everyone, you are welcome to submit further questions into the queue. Dr. Killian, thank you for getting through your slides in short order so that we have this opportunity to have the QA conversation. I have a couple of questions regarding, if we can go back to the beginning of your talk about bone density and how that plays into the conversation of what type of intervention might be needed. So someone asked for some clarification around the comment that there is not a lot of literature reporting of low bone density in Rett syndrome. And we know that there is. So can you clarify if you were speaking specifically about in spinal column versus other areas of the body, and how that impacts the discussion about surgical intervention?
Well, bone density as measured by a bone densiometry. Number one, we don't have very good data that shows us normal and then girls who are neuromuscular. So I think it was from the Australian group, was that their interpretation was that overall they have yet to prove that the bone density overall, so you're evaluating the spine and or the proximal femur, that overall the numbers, while they may be low, they're not statistically lower than normal girls. So yes, I think parents will, relate where their child's leg simply got caught on the door frame as they were pushing them through the door and their tibia broke, or the physical therapist had come over and had been a couple of weeks and working on the knee deformity. Now suddenly the distal femur broke. But there have to be better measures, and the measures probably have to become a little bit more specific. But there's not a study that says statistically, or that there's something as part of the Rett. I think most of the osteopenia that occurs is simply a result of that we're non-ambulatory, and oftentimes we may have a delay in getting a G-tube to boost our caloric intake, and that therefore there's a 2 to 4 year window where skeletal development and the density of the bone is diminished, but it may not be something that we can measure. We just see we certainly see perhaps more fractures in girls with Rett syndrome than I typically would see in children who have cerebral palsy who are in a similar wheelchair situation. And again, that's more anecdotal on my part.
Okay. Thank you. And if anyone has questions needing further clarification on that, please go ahead and put them in the queue. So we've talked a lot about that window of making decisions of when to get x-rays, how to be x-rayed, how to interpret the x-ray and develop a course of action. We have a number of families that are, and we talked about this when we were preparing for the webcast, at this particular time of year in the United States, early November, a lot of families are scheduled for surgery over the next few months, having decided they're coming off of summer, their weight is good, health is good, cold and flu season hasn't gotten terrible yet, and they can have time to be home when it was already holiday time for school to be out to recover. Do you have any, for this group of families who came to the webcast today, any recommendations that you've seen as best practices for preparing for surgery, things that are best practices at the time of discharge to help that transition from hospital to home go successfully and for recovery?
So preoperatively, other than multivitamin with iron and increased intake of vitamin D3, somewhere in the 1,500 international units per day, is part of the preoperative plan. We ask the family 2 or 3 days, not the night before, but 2 or 3 days before surgery to do sort of a limited bowel prep. That is, if you normally give stool softeners and things like that, whatever you can do to sort of minimize the risk of severe constipation from the narcotics immediately postoperatively, I think is important. Postoperatively, usually the girls don't require the iron with their multivitamins. Usually most of them leave the hospital with a satisfactory hematocrit. But I think the most important thing postoperatively, other than, again, your multivitamin, your vitamin D3, is to get them back into their regular routine. There's nothing better than seeing, a smile on our patients on post-op day 3 or 4 that lets them know, the discomfort of the surgical procedure is markedly diminishing, their needs for narcotics are decreasing, and they are making the transition that whatever just happened and in the past 72 hours is now behind me, and my family and the physical therapist are ready to get me back into my regular routine. I think that contributes to their recovery and gets them back in school very quickly. With regards to physical therapy, I think, like I said in our talk, if you have a fusion to the pelvis, we just go very slowly in terms of working on any sort of hip flexion or knee flexion. Similar to children with cerebral palsy, all of these kids will seem to be very tight in their lower extremities for the first 3 or 4 months. There's certainly no pressure on the nerves, so some of this just relates to the intense healing that's going on, and the family and the therapist will often relate that somewhere between the 3rd and the 6th month post-op that suddenly the legs relaxed or the hips became looser, or getting back into our prone standard that we allow sooner than that was suddenly improved. So again, getting the girls back onto their schedule, allowing them to resume some of their lower extremity therapy, we think is important. And certainly that then contributes a general sense of wellness, contributes to rapid incorporation of the fusion mass, which then makes them feel better as soon as their fusion is solid.
Okay, thank you. In terms of actual in-hospital conversations, prepping for surgery and for discharge, I know that you, because you're so familiar with Rett syndrome, probably have a high degree of conversation with your anesthetist, with the anesthesiologist, about managing and identifying the different breathing issues that we see in Rett syndrome coming off of anesthesia and preparing the ICU for that. For families who are working with hospitals and really good orthopedic surgeons who just may not be as familiar with Rett syndrome, do you have some ideas of things that they should bring up and make sure that the whole team, pre-surgical, post-op, and ICU and discharge, should be aware of?
Well, number one, most of the intensivists are good pulmonologists. However, Dr. Percy has always had us have a pulmonologist evaluate them and see them usually a month before they undergo their surgical procedure. So there's some sort of generalized, there's an evaluation by that particular girl with someone who is comfortable with all forms of neuromuscular disorders. So the pulmonologist sort of helps us with that. Our biggest concerns for altered respiration go to two things. One is either undiagnosed atelectasis. There is a concern about, we ask you every time we take an x-ray, we're always asking ourselves, is there an absolute need for that? So there are some clinicians who may not get as many postoperative chest x-rays as another clinician. And I think having a high index of suspicion that, or the family relating that, this is just not how she is normally, gives one of two things. Either number one, it means that we have some undiagnosed early pneumonia or atelectasis in some segment of the lung that didn't pop back open, or there's a problem with secretions. Or number two, as it relates to the surgery, in girls who are very, very skinny and who have a great deal of deformity, occasionally a certain part of the duodenum may get rotated through no fault of the surgery, but it gets rotated and then it gets squeezed. So increasing abdominal distension, increasing irritability makes the orthopedist and the intensivist become concerned as to whether or not you're developing a superior mesenteric artery obstruction. And by the same token, if the family says this is just not, how she normally is, even when she's had other surgeries, and I think most families will tell you that spine surgery is much easier than hip surgery. So if you've had families who've gone through both of them, and they've spoken to other families, they know that after that first post-op day 2, that most of their girls are starting to come back to being their usual sweet selves. So increasing irritability, increased work of breathing, increased laboring, or desaturation are all issues. And yes, I think everybody in the ICU, is aware of all those potential complications, and we evaluate them appropriately.
Okay, thank you very much. We've got a couple more questions around scoliosis surgery intervention, and then in our remaining minutes, I'd like to move on to some of the questions about spasticity, rigidity, and hip dysplasia. Okay, because I think we just have an endless number of questions here, trying to manage them. Regarding scoliosis, what is your thought on lumbar curve versus thoracic curve in deciding when surgery is needed? Is there a difference?
There's really not a difference. We take the flexibility of the curve into account. So because we know the tools that we have now are so powerful in terms of being able to decrease the deformity, that whereas how I was trained 20, 25 years ago, you could only untwist the spine so much, and you had to accept some degree of residual deformity. So the newer instrumentation means that the family has time to prepare. They don't have 2 or 3 years to prepare, because again, as the curve gets stiffer, the bone seems to become more osteopenic. There's increased blood loss associated with stiffer, larger curves. So, coming to that decision making, I think is on two things. One is the general health of the girl, and then number two is the absolute stiffness of the curve. And very stiff curves should be addressed sooner if the family's desire is that their child have the best possible sitting balance long term.
Okay, and this kind of final question on scoliosis, we have more in the queue. We'll take them offline for a QA document. This is a big one that I'm seeing across specialties. The question of families who are looking and hearing and digesting a lot of conversation around cure, around gene therapy, and the potential opportunity if these interventions come to fruition for our children versus making decisions surgically now that might close off opportunities for improvements if a treatment comes. I'm not sure if this question is clear. What are your thoughts on families who are putting bets on a curative or transformative intervention in the near future and might be deciding to delay surgical intervention that hip to spine to pelvic area? I'm going to stop there and let you try to answer this the best you can.
Okay. Well, probably the two people who can talk about what a cure might look like and where it might affect a child with Rett syndrome is probably, Dr. Percy or Dr. Skinner, the geneticist. So from an orthopedic point of view, we're always trying to be minimalists. The families may not look at it like that, but we are. We're trying to restore a joint to an improved range of motion and or prevent arthritis and pain. And in the case of spinal deformity, all of us are trying to prevent the deformity from causing heart or lung issues, which are unrelated to Rett, or maintain sitting balance so that our quality of care and our ability to interact with our family and at school is preserved. So most of us are looking at the 10-year to 20-year timeline when we are talking about a surgical procedure. I don't think any of these orthopedics orthopedic deformities are going to be affected by a cure in that the purpose of the MECP2 gene in terms of signaling, both in the peripheral and central nervous system, is very complex. So, yes, we would like to see that there's an overall diminished degree of abnormal tone, which would make perhaps some of these deformities less severe or delayed in onset. But I think in terms of cognitively and hopefully in terms of speech, those would probably be the first two places where if we're going to see something dramatic, I would expect a cure to start there. And then if the neurodevelopmental process can be reversed, then yes, you may never have to have another child have scoliosis surgery or be at less risk for a hip dislocation. But I think based on what we have right now, your goal is that given where your child is today, based on the physical examination, the x-rays, and the absence or presence of pain, you're probably getting the best recommendations that are going to hopefully hold up for her for the next 20 to 30 years. And that, it's real difficult to second guess that when your child has a significant deformity and or pain.
Thank you. That was a very good answer to a complex question. We appreciate it. We're getting near the end of time, but I've got a couple of things that I hope we can knock out on a sort of a practical practical level. One of them is on bracing, right? We know these braces get really hot. So if child best course of support is bracing of any kind on any part of the body, how do we deal with this in places where we live where it's very hot?
Understand. I tell the families that if you are getting, 10 to 12 hours of brace wear, and if you can do it at nighttime, especially when it's during the summer months or the family is very active, I tell you, just try and do that. We certainly don't want the girls getting overheated. And if you're going to be out and about a lot, I agree. It's hard to do it. So it's the cumulative amount of wear that is of benefit. And number two, I think it's what doesn't medically harm the patient. So if they're more prone to that, then I think you wear it when you're indoors or in school or at nighttime. And then if you're the sort of family that's at the ballpark for 6 hours every weekend watching your siblings, then it's kind of hard to be in a brace, and you probably should not be.
Okay, thank you. That's great advice. So kind of look at the cumulative time and don't panic on the day-to-day.
Correct.
In a nutshell?
Yes, that's perfect.
Okay.
I can make them even shorter for the last three questions or to help us out. Keep going.
Okay. So we've got quite a few families whose children have grown into adults and they've been through scoliosis surgery and hip correction and are facing a lot of spasticity and rigidity. I know those are two different things, but for our adult population, can you give some closing thoughts on management of that post-surgical, if there is anything that you can recommend, especially when it comes to sitting and changing and movement? Is it typical to have increased rigidity and spasticity after intervention, or is that more progression of the disease and age and not related to any of these interventions? Do you have a thought on that?
Yeah, well, without putting words in Dr. Percy's mouth, we can certainly ask for his input. I think it's part of the disease process. I think there may be spasticity very early, but when I compare the physical examination of a Rett girl with a typical hemiplegic due to a stroke, that sort of spasticity is not as apparent. And we move on to dystonia. And then I think shortly thereafter, you develop a Parkinson-like rigidity that the levodopa and other drugs that have been developed have maybe 1 to 2 years of positive effect, and then you seem to just not get continued improvement. So I think we have to push the musculoskeletal or movement disorder neurologists to continue to push for new investigative studies that will show us how do we address that. And if there is more similarity to the Parkinson group, then perhaps use some of their information and apply that to this particular group of girls. But in terms of particularly Botox or baclofen, I've just not seen it to be dramatically improving in terms of a much more flexible, improved joint range of motion in this particular disorder.
Okay, thank you. And last, just if you can hit on it, this will be your last question for the day, and I know you need to get back into clinic. Looking at other joints, you talked about other joints, knees and ankles. Do you see anything significant happening in these areas that parents should be aware of and attentive to and thinking about?
Well, I think for the ankle, range of motion is very important. Sometimes nighttime splinting is of benefit. Keeping the feet in a plantigrade position so that weight bearing is possible for as long as possible is very important. For knee deformities that are completely refractory to physical therapy. I think more people have gone to bony surgical procedures to realign the leg in an attempt to improve your ability to be positioned on a stander or in a walker. And that hamstring lengthenings per se don't seem to hold up at 2 years. But again, from the orthopedic point of view, we would like a cure from a pharmaceutical vendor that addresses the dystonia, because that dense tone issue is certainly a problem for us and for the family and the girl.
Okay, thank you.
Well, it's been my pleasure.
Well, we really appreciate your collective years of experience, the networking that you have done with others in the field, both within the field of orthopedics and especially with Dr. Percy and many of the leaders in the Rett community who have really expanded your thinking beyond the technical neuromuscular issues that you see regularly in Rett syndrome, but how you've integrated all of your knowledge about the progression of this disorder and all of the breaking news in the field that we're also very helpful about. I really appreciate the fact that you really take all of this into consideration as you're making your recommendations for course of action with our girls and women and boys with Rett syndrome. The field is changing, and we are so optimistic that better interventions will come, whether they're surgical, technical, or in the area of broader MECP2 intervention. So thank you, and we appreciate your continued support and your relationship, Dr. Killian, and I will circle back with you with some of the questions that started to get a little bit more specific on the broader topics that we talked about, but you did a fantastic job today, and we really appreciate your time.
Well, thank you for the opportunity to join you and all these wonderful families, and we will certainly make ourselves available to get those last questions answered for you.
Thank you very much. I'm going to take the screen back, if I may, just to talk about some things that are coming up in the near future for our broader community in closing. And if you'd like to stay on, you're welcome to. If you need to hop off, we understand, and we really appreciate you being with us today. Okay, so everybody, in conclusion, there's just a few things that I'd like to say. Let's come off of this topic and look at the bigger picture in the field of Rett syndrome. And I want you all to be attentive to a current survey that is available that we're asking all parents and caregivers to participate in, and it's called the Rett Syndrome Burden of Illness Survey. We're looking for parents and caregivers to complete this survey, as well as healthcare providers, whether it's an educator, therapist, physician, who has experienced a few children with Rett syndrome and can answer this survey to participate. The goal is to get enough contributions of data to help shape policy around funding and resources for Rett syndrome. Now, whether that is for DME equipment, whether it's for support services, whether it's for payer information towards therapeutics that are coming. A study of this size and magnitude has never been done for Rett syndrome. It's currently open. It will be only open for a short period of time, and we are asking every family to participate. You will be compensated for your time. If you are interested and would make the time to complete the survey, if you would please email Brittany Gibson at rettsyndrome.org. Her email address is right there on the screen, bgibson@rettsyndrome.org. She'll give you a unique access code so that you can go in and complete the survey. And as I mentioned, you'll be compensated for your time. And there is a separate survey for healthcare providers. So if you have someone who's seen your child that has experience with maybe 2, 3, 4, 5 other children with Rett syndrome, children or adults, please have them contact Brittany as well and ask for a code. We really appreciate your contributing. This will be a really important survey data. I also want to mention in closing our next RettEd, which will be continuing on this conversation of research There are multiple clinical trials that are currently enrolling for Rett syndrome. Next month on Tuesday, December 10th at 1 o'clock Eastern, Dr. Tim Benke will be giving us an update on all the current trials that are open for enrollment, the ones that have recently closed, and ones that are coming on the horizon. So we hope that you go to rettsyndrome.org/RettEd, and you'll see a link to register for next month's webcast. I also, in closing, want to reinforce that we are committed to continuing community education programs for Rett syndrome in a variety of ways so that you can learn in the way that is best for you and your family at this moment in time. So looking to 2020, you can expect that we will continue with monthly live RettEd webcasts such as this one. When you are prompted for a survey at the end of today's call, or when you get the recording link, we're going to ask you if there are additional topics that you'd like us to tackle in these RettEd webcasts. Please submit it. We absolutely make the calendar based on what is on your mind and what you're facing in your life at this time, whether it's medical, therapeutic, quality of life. No topic is insignificant with Rett syndrome, and we're committed to continuing these webcasts at no charge, and we appreciate sponsors who have helped us be able to provide this vehicle for you. Also visit the website because we have about 2 years worth of recordings in our webcast library that are all accessible for you, and we know that issues in your life change over time. So something that wasn't important today might become important tomorrow, so you can always access this library. We also know that time together in person, face-to-face with each other as parents and caregivers with experts is invaluable, and we will be continuing to conduct Ed Days, getting together on a Saturday in different parts of the country in 2020 to bring you together with experts in your community. Look for those dates to be published soon. And much requested is another Rett getaway in 2020. So we're happy to announce that we have one scheduled in San Diego, June 19 and 20th, which will include great excursions to Legoland and many of the attractions in San Diego. And in particular, we are partnering with the Mosca Foundation to do adapted surfing in San Diego. So if you're looking towards the summer and making your plans, consider this. This will be really unique, comfortable way to travel. Try something that maybe you haven't considered an option for your child before. We believe in a life without limits, and we want to show you how. So we don't have information quite yet on our website, but we want you to get these dates on your calendar, and we hope that you join us in San Diego. Okay, and on that note, we've gone a little bit long. This was a really important topic to all of us. Dr. Killian, again, thank you for your time and your information. Thank you to all of our attendees for submitting such thoughtful, important, relevant questions, and we will tackle the QA document and get that out to everybody. So in closing, we wish you all be well, enjoy the holidays. Thank you again for all of your activity during October Awareness Month, and we look forward to seeing you again next month on our webcast of clinical trials. Thank you very much and have a great day, everyone. Bye-bye.